This conference will now be recorded.
Okay, AnCan is grateful to the following sponsors for making the recordings possible: Bayer, Foundation Medicine, Janssen, Myriad Genetics, Novartis, Telix, and Blue Earth Diagnostics, and all the donors who visit ancan.org and make a donation. AnCan,
and Foundation Medicine.
I said that. That was included. AnCan notes that it does not accept sponsored promotions. Any drugs, protocols, or devices recommended in our discussions are based solely on anecdotal peer experience or clinical evidence. Please consult your own provider for personal medical advice. We encourage you to discuss anything you hear in our sessions with your own medical team. Thank you. Okay, so the first person on the list today that we have is Bob. So if you are not speaking, it's helpful to mute your microphone so we don't get a lot of noise. I'm probably going to be the worst offender because someone is blowing leaves right outside my office here. Bob, how old are you?
83.
Okay, where do you live?
Santa Barbara, California.
Right up the road. We've been trying to plan a trip up there. And when were you first diagnosed?
When I was 75.
And at that point, what got you into the doctor? What tests did they do? What did a biopsy show?
I've done regular annual PSAs. When I was 75, it went from the prior year from 3 to 10. So that sort of got me in gear. Biopsy showed 2 lesions, both 3 plus 4. In one lesion, the 4 was 5%. In the other lesion, it was 10%. MRI indicated that it was encapsulated within the margins of the prostate, and the PET scan said there was no migration. So I've been in that mode for the last 8 years, basically. Same number, 10, goes up to 12, goes down to 8, but it hasn't much varied. The MRIs have noted no suspicious lesions detected until my last MRI in March, where the reader of the MRI said there's early focal enhancement, 1.6 centimeter lesion, and recommended biopsy. So that's kind of where I am right now. That's a change over the last 8 years. I've asked for another reading of the MRI by another doctor and waiting to get that. Don't know if I'm going to do a biopsy or not. And if I were to do a biopsy, I'd have to make a choice of, which kind to do, whether MRI assisted or the ultrasound, micro ultrasound with the MRI fusion. So that's kind of where I am right now. It's been business as usual for the past 8 years, and maybe some change in direction. I hope not, but based on this last MRI in March.
Okay, so I'd like to find out, when you were 8 years ago, was that a fusion biopsy?
No, I didn't even get a biopsy then. The
You said it was 3+4 though, with 5%.
well, no, I didn't know that then. I assume it was in retrospect. The urologist recommended just do active surveillance, don't need a biopsy, don't need anything else, until 3 years ago, where the PSA jumped from 10 to 18. I guessed it was probably prostatitis, but that's what did bring on the biopsy and the MRI. Now, my assumption, it had been always the same, 3+4, that's an assumption. But that was the advice initially. Don't do anything, just monitor.
But was that biopsy an MRI fusion, or was that a random biopsy at that point?
No, it's a random biopsy.
Okay, so at that point, you could say you really don't know what you had. Random biopsies are like pin the tail on the donkey, and you kind of don't know what was there. At this point here, where they say there's focal enhancement, that was an MRI or the PET scan?
No, that was MRI.
And when was your last PET scan?
22, three years ago.
Okay. So I think at this point, you haven't had a biopsy that would be considered standard, whether it's an MRI fusion biopsy or the nano ultrasound. They are apparently as good as each other. Is your prostate markedly enlarged? Do you know the volume of the prostate?
30.
Okay. So you wouldn't expect that the PSA would be high just because of the enlarged prostate.
No.
There are biomarkers that are often considered as a interval between the findings of the elevated PSA or the MRI, and then actually doing a biopsy. And they would be things like ExoDx, My Prostate Score 2, or EpiSwitch PSE, EpiSwitch PSE. All of those may allow you to further put off moving ahead with the biopsy. And then at such time as you decide to do a biopsy, one, you want to have either the ultrasound or the MRI guidance, but you want to send the tissue off both for a deciphered screen on the genetics of the tumor, but also get another reading from a pathologist who's an expert in prostate, like Dr. Jonathan Epstein, Dr. Ming Zhou, or in Ohio, Dr. Jesse McKinney. Those people can help, because up to 25% of the people who are getting a diagnosis from local entities based on pathology, when the expert looks at it, they're going to say no. And it could be no either way. So I think at this point, you've got to confirm your diagnosis.
Yep.
Other comments from anybody else?
Yeah, I think we should advise you this isn't really the right group for you, Bob. How did you find us?
Well, I'm shopping groups. Last week I was in the active surveillance group.
Okay.
And then I thought, because I'm in the favorable intermediate category, that this group might also be interesting. So I just thought I would check it out.
No, I mean, it's more for your, out of concern for you than it is for us. So you're very welcome here. But there's a lot of people in AS who don't want to talk about treatment. And so the way that we run is that the AS group doesn't discuss treatment. This group largely discusses treatment.
Right.
But in terms of maintaining you on AS, there's going to be a lot more discussion that will interest you in the AS group than in this group, because most of the guys who are here have already graduated from AS and made a decision to intervene with something more active than active surveillance protocol.
Got it. Okay.
But at this point, Bob, I don't think you have a diagnosis.
Not yet.
I mean, I think both in terms of a random biopsy and in terms of getting those additional reviews, I think that's a step before deciding whether it's treatment or not.
Right.
We've had a couple of people stop in. Henry, are you going to need some
Hold
time?
hold on a minute. Let's just finish up with Bob.
Okay.
Well,
So
the most refreshing thing I heard from the other group was from an 85-year-old. He said no matter what, he's not getting treatment just because of quality of life. And I lean firmly in that direction.
yeah, I know who you're talking about, and he's doing great. And that's why we kind of keep you guys, all you AS guys, in that group, so you don't have to hear about surgery, and you don't have to hear about radiation, and you don't have to hear about short-term or hormone therapy or any of that. Are you signed up to our email list?
Yeah.
Okay. Have you ticked the box AS and for
Yeah. I thought I'd sign up for both, and
yeah, that's fine. No, I
As-
just wanted to
as-
make sure you
as-
were, otherwise I
as
was
I
going to
like
take
the
care of it. Otherwise I'm going to take care of it. And it sounds like you don't need any help speaking freely. You're handling this very well. But we do have a very good men speaking freely group, including at least one regular 86-year-old in there who's exceptionally active. Right, Dr. John?
You're right, Rick.
So, so if you want to add that to your list, you know how to do it. Go back in and come join us in Men Speaking Freely.
Sounds great. Could I go back to what you said about 3 possible preliminary tests prior to making a decision on? Because I didn't write those down when you said them.
Okay. So again, at 85, what kind of diagnostic stuff you want to do? I think anybody will be in question, but I wouldn't rush right into getting a biopsy because it's still, it's still being manipulated or invaded. ExoDx, ExoDx is a urine test.
Okay.
Another one is My Prostate Score 2. My Prostate Score 2.
Okay.
And then the third one that I'm going to recommend is the EpiSwitch EpiSwitch and PSE. A lot of urologists will still use the 4K test, but that's an older test. I think these are more helpful. But even so, let's say you do this, and what they're trying to do is predict the likelihood that this disease is going to progress over the next 10 to 15 years. And the question comes down, how worried are you that at 95, you may have more aggressive disease? I think the main thing that,
not too worried.
Yeah, so I mean, it may be pretty much, I want to know, do I have a lot of metastasis all over the place now? And it may very well be that the PET scan is sufficient to reassure you that there's not big tumors floating around. And that may be all you want to do. And then the question is it just choosing not to do more, or is that, I mean, it's really inactive surveillance versus active surveillance. And Rick and I were having a talk about that just in terms of age and screening and evaluation earlier.
Yeah, I mean, it was a very good conversation that Dr. Mark and I were having, which really pertains to everybody in this group and in the AS group, because AnCan as an organization encourages testing at any age, provided it's accompanied by shared or informed decision making. We don't agree you stop at 70. If Bob had stopped at 70, we wouldn't be watching him now, and he wouldn't have been pursuing, and so, but he hasn't gone through treatment anyway. And so, you know, the argument is, well, look, that's why we don't need to test him, because he's gone 10 years since we started and he didn't go anywhere, so why even bother him? I feel, and I think most of us at AnCan feel, you should be able to make that decision yourself. So you decide you don't want to do it. Now, Mark feels a little differently, but largely because he thinks you don't get very good information when you do the informed decision making, and he's right.
Yeah.
You don't. But at the same time, you can if you want, and you can opt to do it and pursue it. I don't like taking. For us at AnCan, PSA test is only about information. It doesn't tell you anything else. It's just one data point, and then you have to decide what you want to do with that data point moving forward. So I'm curious if anybody else in the group has, this is a very controversial issue, as most of you know. I'm curious if anybody else in the group has an opinion on this.
Rick, and I would say you're referring to screening, not after treatment, because that's a totally different situation.
Right, exactly. I'm definitely referring to screening. Yes, Michael.
Oh, so I know this has been a hotly talked about subject, and I've read some of the things that have been said, Rick. So just a short thing, you know, a number of years ago, I was working at a federal healthcare clinic, and that was when the PSA was not being recommended, or, you know, for certain age groups. So I was seeing a ton of older gentlemen in this federal healthcare clinic where money is a big thing because we only have so many dollars to deal with. I kept testing all my male patients. I mean, you know, I asked their permission to test, but my opinion was, I'm drawing your blood work anyway, and I think I should test. And I would say I semi got called on the carpet about it. You know, told you're not going according to the guidelines. And I said, well, I think guidelines are guidelines, they're not rules. And I think that I should be testing everybody. And I think of a PSA test like a fire alarm in my apartment. Every time it goes off, is it a fire? No. But every time it goes off, I'm gonna get up and make sure I don't smell smoke. If that makes sense.
Any other comments here?
Yeah, no, it makes a lot of sense. My criterion for PSA has always been not too much worry about it, because it goes up and down by nature. You know, it's chemical, and everything chemical is changeable. But if it doubled in a short period of time, then I think I might be, you know, more prone to, you know, take a further look. And again, from my point of view, I don't mind testing if it's non-invasive. If it's invasive, such as a what we're, you know, talking about, then I'm gonna take a while to think it through.
Did they give you a PI-RADS score on that enhancement in the
Yeah, he
MRI?
gave me a 5.
Okay,
But
so
that's the eye of the beholder.
absolutely, there's a big variation between one person and another. but traditionally that's thought to have about a 65% chance of revealing significant disease. Still doesn't tell you what to do,
Yeah.
but it does suggest that the likelihood that it could be more than 3 plus 4.
And he said it's a 1.5 centimeter, which is sort of average in prostate lesions from what I've read. So it's not alarming based on size. But if it's no longer a 3 plus 4, but if it's a 4 plus 3, then maybe a bit of a different ball game.
Yeah.
Well, and then hopefully you'll come back once you figure out what you're doing and share that decision about trying treatment or remaining in active surveillance. Hey, Boykin.
Hey, Mark. Oh, yeah. Sorry, I'm on mute.
I just listened to a short 10-minute video from Matt Cooperberg at UCSF, and the subject was from a poster he presented at GU ASCO as to whether MRI can replace biopsies. And in his concluding statement, he said, and it said on the screen, that the problem is not the MRIs that are not accurate, it's the PI-RADS scores that are not accurate, and that we don't have good enough technology to accurately read those PI-RADS scores, although he actually said for sure, because it stuck in my mind, he said for sure that will improve. So, what they're saying is, just like Bob said, it's in the eyes of the beholder, but with AI and large databases, the reading of those PI-RADS scores can only improve.
I don't know if that was the talk where they were talking about looking cell by cell and defining a cell by its neighbor as well as the cell itself, because it's those patterns and the interaction of a group of cells that can matter. So, yeah, I think that there's a lot more to gain from the MRI than we learned from PI-RADS. So hopefully AI interpreting the MRIs will lead to better information that we can use. But we're not there yet. Pete had to leave, so let's move on to Carl. Carl, if you want to let us know how old you are.
All right, yes, I just turned everything back on. So I'm 67, I'll be 68 next month. My father and two brothers have both had radical prostatectomies. My father when he was in his mid-60s, my brothers when they were in their early 50s. I've been monitoring my PSA since I was 40, and it's always been in the 2s, high 1s. Went through monitoring and normal monitoring in February, and it jumped up to 11. So my physician referred me to a urologist who recommended a biopsy. I had a biopsy, and I started out with MRI that recognized two lesions, both about 0.8 to 0.9 centimeters. One attenuated PRADS at 4. The other one attenuated at 2. So they did a ultrasound guided biopsy in May. That came back on the basically on the lesion that attenuated at 4 with Gleason score of 3 plus 3, with 3% of the cores testing what they concluded to be positive for prostate cancer. So I'm currently actually I'm going in tomorrow. I had a PET scan 2 weeks ago, going into the urologist, not tomorrow, but next week, for a recommendation. The PET scan is indicating contained to the prostate. So I'm really at a point of collecting information. I'm concerned about the quality of life issues related to a prostatectomy. Again, my father and brothers have gone through that, but they were younger than I am. So my urologist is recommending active surveillance. I'm kind of waiting till I get all the results to seek a second opinion. So that's sort of where I sit here today and why I sought out information coming from this group. I did notice something that popped up related to an MRI based outcome, a prostatectomy outcome suggestion that they could use some new technologies to assess the likelihood of positive outcomes, I guess. And so that's kind of one of the things I was interested in to hear about.
Where are you located?
Sorry, I'm in the western suburbs of Chicago, and just for awareness, 2 years ago I had a radical nephrectomy of the left kidney. I had kidney cancer, so this is my second round.
Okay, and have you been tested, or brother's been tested, father, for germline genetic changes?
I had a genetic test, and actually they were looking for genetic abnormalities related to my kidney cancer. They did not find that, but they indicated, and I apologize, I don't have it at the top of my head, but a genetic abnormality for related to prostate cancer.
They did find that.
Yes, and it was H something or other, and to be honest with you, I can't remember what it was.
Okay. Who spoke up there? I didn't hear. Okay, so there was a genetic change in there, and that. Who are you seeing in Chicago? Who's your urologist?
So I'm with the Northwestern group, and I'm in the western suburbs. It's Dr. Bachman is my urologist. I also have an oncologist in Chicago who actually is leaving the practice, Dr. Shinoy, but he specializes in kidney cancers more than prostate cancers.
Mm-hmm.
I'm easily accessible to Chicago. And I've had second opinions from University of Chicago Medical. But again, I've had so far my kidney cancer treatments have all been through Northwestern.
So Northwestern has a rep of not being particularly active surveillance friendly.
Okay.
Certainly, if you go to the, I don't know about the satellites, but certainly in the main center, because Schaefer himself isn't a great proponent of active surveillance, and that
I read his book.
Down. Yeah, so it trickles down. Now, there are a couple of docs who are active surveillance friendly. If you've had some contact with University of Chicago, then we would say go talk to Scott Egner, because he will encourage you to do active surveillance if he thinks it's at all possible.
Could you spell Dr. Egner's name for us?
Yeah, I'll put it in the chat window for you.
Okay.
And I'll
Perfect,
put a link in the chat window. The chat window are those two little squares. So give me a second and I will put that in the chat window. And he knows AnCan very, very well. So
Oh, that's wonderful.
if you are at all inclined to follow this with active surveillance, then yes, he's the guy. I'm trying to figure out, Dr. John, I'm trying to figure out which variant, which mutation that is that starts with a, there is one, I think.
Well,
Or were they
there's
just thinking?
HOXB13. HOXB13 will
That's it.
increase.
Yeah.
It runs in the germline and it carries something like a 10 times or 20 times more common prostate cancer. There's HSD3B1. I'm looking at my notes. It's not like I'm doing this off the top of my head.
HSB sounds familiar. I'm actually, as we're speaking, I'm logging onto my chart because I know I have it in my chart. So, but obviously we'll keep going for sake of everybody's interest.
Okay. And that, so that's, and then of course they could have been just talking about HRR, which is homologous recombination, where there's a whole bunch of different possible genes. That's a wastebasket category. So those are the three that show up in my cheat sheet here for H's. But it might be a good situation to go to some of those other, not the tests that Mark mentioned before, but maybe would be a good opportunity for a Decipher test or an Artera AI test to see whether it would be safe to go AS or not. And they'll look at, Decipher will look at some genes too.
Rick, have you mentioned in the past, I forget, you had mentioned a group with germline genetic changes. Was that someone in Chicago?
I'm not sure of your question. I don't understand your question.
A geneticist that he might talk to, an oncologist who focuses on those with the genetic mutations. I know you've mentioned a group with mutations.
No, I mean, so I would say, I mean, Egner's good on this stuff, and I would say that I would start with Egner. I mean, if you wanted a medical oncologist at U of C, we can certainly give you names. I've heard of Shenoy. Frankly, we're not as big a fans of the prostate GU oncologists at Northwestern as we are of those at U of C. But I wouldn't. If you have HOXB or the HSB, I'd be discussing that with Egner. I think he's very well educated. He's going to be able to advise you on those.
Okay. Yeah, I'm not getting my fingers on it right at the moment. I apologize.
Okay. Any other comments here?
Just right now, the initial after the biopsy results came in, we had a consult before the PET scan with the urologist out here in the suburbs, and he suggested that unless we found something indicating metastasis in the PET scan, that he was going to recommend active surveillance, and that's kind of where I'm leaning at the moment.
And you were 3+4, you said, is that right? How much?
Oh, it was actually 3+3.
Oh, 3+3. Look, and have you had it? Have you had that reread or not?
No, sir.
Okay, so whatever you do, I'd send it to either to one of the three pathologists that Dr. Mark mentioned. Maybe somebody will put their contact details in the chat window, or I can try to do that in a minute. That is really essential. That's really essential, because if it is 3+3 and it's confirmed 3+3, there's absolutely no reason, whatever anybody tells you, to do treatment. I mean, we have a guy, he's not in the group tonight, who's got 11 out of 12 cores with 3+3. And the top urologists in North America are telling him you're fine. Okay. So we don't believe that 3+3 calls for treatment under any circumstances or any type of treatment. Doesn't need focal. 3+4 is a different ballgame.
Sure.
And but you know, if you're 3+3, however many cores you have, I would. That's why I really would urge you to see Egner or Helfand is another very good doctor, Brian Helfand. But that, you know, I would go to Egner, especially since you have the kidney cancer complication, because they have the doctors to be following you, and they're aware of that.
Oh, that's super helpful.
I get concerned when people are in the Northwestern system, because our experience has been that they'll tell you you need surgery at the drop of a hat, not even radiation, and then they'll move you to radiation. But they're too quick to intervene at Northwestern, in our view.
Yeah.
So
this is very helpful. Thank you.
And thanks very much, Stuart, for putting in that information for Ming Zhou. I'll get the information for Dr. Epstein. Either one are great, and you know, get that sent off like right away. That's just super important, especially given your family history.
And make sure that you send them information about the genetics as well. Yep, let them have the whole picture and not just the slide or a chunk of tissue. Try to get them as much information as you have to review it.
Okay, that's super helpful. Well, I appreciate it. Thanks for the opportunity to share my situation, and certainly appreciate the feedback. This is super helpful. Thank you.
Carly, you signed up with us or to get the reminders?
I don't know that I am. This popped up in my Facebook feed, and I said, yeah, okay. I want to jump on this.
Okay, so just put in the chat window. First of all, I just put Dr. Epstein's link for it, so you'll get all the information for Dr. Epstein. Dr. Zhou, who trained under Dr. Epstein, is right above. Both of those guys will talk to you. Okay. They're pathologists who don't live in a cave, and they like to talk to their patients. So both of them will talk to you about their findings. Choose one. You don't really need both. If you, I put further up Dr. Egner's a link to Dr. Egner, so you can follow up with that there. And then if you put your email in the chat window, either send or the organizers personally, or put it in openly if you're willing, and then we'll make sure we sign you up for this group. And then we have an active as you heard before, we have an active surveillance group that meets every Wednesday that would normally be navigating you, because we don't talk about treatment in that group at all. We try and get you to the point where you decide you want treatment.
Okay. All right, I'm uploading my Gmail account right now.
I see it. Got it. Thank you.
Thank you very much.
I want to mention that for the newbies here, go to the website ancan.org and look through it, because this is just one small component. There are numerous groups, activities, meetings, events, information online, webinar setups. There's a lot going on. And if you just come every other Monday, you're going to miss out on a whole lot of information that may be beneficial across the board. So learn about the group by visiting the website. If we have nothing else there for Carl, Michael, you're up.
So I kind of want to present what's fixing to that I'm fixing to get an MRI, but kind of give a little bit of my history and see a little bit about opinion on this 1.5 versus 3 Tesla. But mine is more complicated. I had chondrosarcoma in 2019, my left femur. So half my left femur is metal. And I've been kind of dwelling since in 2 weeks I go down to get an MRI and a repeat biopsy on some of these reports and things. And my diffusion weighted images and my ADS, I'm not sure what that means, images are rendered not very useful in my MRIs. And I guess when I read these MRIs over the course of several years, I think they're doing them on 1.5 because of all that metal in my body. Does anybody have any thoughts on that or have
I
any
think you're right.
experience?
I
Okay.
think you're right. If you use a 3 Tesla machine and there's metal in you, there could be trouble. On the other hand, even on a 1.5 Tesla machine, the metal nearby can have degraded the images on those water diffusion indices. And so there could even be some interference. Now, usually the radiologist that reads it will say that there's degradation of the images because of nearby metal or whatever. Usually they should, I think, give a little description about the quality of their report, of their images, and therefore of their report. But I agree with you. They probably use that because of your metal.
And
So
they did talk about that a little bit. Yes.
Michael, it's interesting. You might want to connect with Zali here because he's going through the same situation on that, if I recall, Zali, with the 1.5 MRI and metal. One thing that might be useful is to look at nano ultrasound. Again, they should be able to get a better approach with the micro ultrasound or nano ultrasound that uses a very high frequency, and the probe is right up against the prostate, and that allows them to see much more clearly. And it appears that while it's not going to give you a good definition of the pelvic sidewalls and other information that you might get from a whole body MRI, certainly to evaluate the prostate and figure out where you are and where the lesion is, micro or nano ultrasound would be a good approach. So I'd certainly recommend that you ask and consider that. In general, the average one of us walking in and getting an MRI with 1.5 versus 3, whether it's used a protocol that's using gadolinium or not, those people who are functioning in a prostate world are going to do okay. When it comes to having the metal there or going to your community hospital and asking for a prostate MRI, it's probably not going to be the same thing. At this stage, I would think that the micro ultrasound is going to be someone who has a special interest in it because it's relatively new. But it's not like you're going to your average urologist who might blindly put a needle in. So if you can find someone in the Chicago area who does that, that's something that I'd think about.
Well, I'm headed. I'm actually over in Montana, and I'm headed
Oh, that's
down
right.
to Phoenix to get this MRI, and then 4 days later do the repeat biopsy, uh, which it's even debatable sometimes whether I should be doing a repeat biopsy, because I did have a low percentage of 4 last year. But I felt like when I read guidelines, and again, forget their guidelines, I know, that because I upgraded to a 3+4 grade group 2 last year, that I should repeat a biopsy at a year to be safe. But I want to say something here, as we talk about uh, hospitals, and of course, I was very displeased with my initial hospital, which was supposed to be a center of excellence, who pushed me strongly. Well, just said I had no choice but to do surgery. Wouldn't even want to consider radiation, nothing, just recommended surgery and told me they could get me in 2 weeks. And then, sought second opinions and got further with that with Mayo down in Phoenix. Um, I did get a reread here in Bozeman on my MRI last year by my community hospital, which had done my first MRI in 2020, I believe it was. And I would say my local community hospital radiologist said a lot more about my prostate MRI than the radiologist did at the Center of Excellence. And it was almost concerning because he commented so much about the 3 different spots that he saw, but then in the end, he made me feel much better about it, because he said, and all this looks completely unchanged from 2023. you know, um, so it's like we were saying, the radiologists, they vary so much from place to place, and what they're going to say and what their opinions are. And my first ever MRI, I had a PI-RADS 5, and that's never been read that way again. It's been 4s ever since.
Any other comments, Ollie? Do you want to pipe in, since your situation is somewhat similar?
Yes, thank you. Yeah, I'm basically a couple small new developments we can talk about later, but yeah, I'm in the same boat because I had the 1.5 and both my MRIs were 1.5 because I have a interstim in my backside for bladder, and both of them were inconclusive. Yet here I am with some positive core samples and also a high PSA, but nobody can tell me, give me a definitive view or screening of it. Um, so yeah, that's it. I'm still kind of up in the air. I do have some small developments when it's my turn, but it looks like I might have to go after that micro ultrasound somewhere here in
Yeah, I
Michigan.
think that's something to look at. Do you know if that's available at Mayo, Rick?
I asked last year, and I was told it wasn't. And then when I chased it a bit from here in Bozeman and looked up, which all the doctors that do anything like that are a long, long ways from Bozeman. I think Fred Hutchins Cancer Center might have been offering it. Looked like one of my better options. I believe that's in Seattle. Or is that in Seattle or Tacoma?
Yeah,
Um,
yeah.
but the only thing I
Seattle.
found was that, when you want to start, when I wanted to ask about maybe seeing somebody for that, it was like they wanted to start me all over into the system. And I'm pretty happy with Mayo and the urologists that I've seen there. And at least for now, I want to follow up with them. I hope they have started doing the micro ultrasound or considering it.
Is it Frendel? You're with Frendel, aren't you?
I'm with Frendel, and I have seen one other doc there. I went to Frendel second because I was interested in the focal treatment. and I don't want to start that discussion. We, you know, he said there wasn't anything there to focally treat because of what he could see. But Frindle is the one that's going to do my biopsy. Yes.
Right.
Um,
I do think I may be wrong, but I do think he's using micro ultrasound with the transperineal now.
okay. I would.
I mean,
So
just send him a note and ask him. I mean, he's a good guy.
he's Rick. They're really hard to get in contact with because it's always the resident that answers you, and I feel like I'm beating my head against the wall sometimes. If it, you know,
Well, I mean, that's good feedback, and I will pass that along if I see him again. But I would send a message to Frendel in your portal, and whoever responds to it responds to it. But send a message to Frendel and say, "Are you using micro ultrasound technology?"
well, I will. I hadn't thought about that. I'll do that now that it's been a year. Maybe they're using it now.
Just a note on the micro, the conventional wisdom seems to be don't get an operator that's done fewer than 30 of them.
Yeah, I mean, if it's Frendel, he'll have done way more at this point.
Ultrasound is very operator dependent. I mean, I can do ultrasound, not of the prostate. I do fast exams for ER for trauma, or I've been trained to, but I haven't touched it in 2 years, and I wouldn't dare depend upon my read now. When I was working in ERs all the time, I was getting pretty good at it. But fast exam is it's pretty easy. It's pretty obvious what you're looking for there.
So yeah, I was told the same thing from the specific. I chose a specific urologist that did the focal, and he told me the same thing that we don't know what to go after. I don't know what to target. So
And
basically, some comments you got.
according to, I believe it's Dr. Klotz, he kind of strongly says that if they're getting he doesn't use these words, but if they're getting a positive sample from an area that doesn't show up on MRI, then that is good, because lesions that don't show up on MRI he says, are much less likely to progress. That
But Michael, that's in a situation where you have a good quality MRI and a reliable machine and setup. And I don't know that that's what your situation might be. So I don't know if we can. What Dr. Klotz is saying is that the genetics that makes these disease spread or escape is what also is similar or involved with showing up on MRI. And if you're not showing up on MRI, you probably don't have the genetic changes in the tissue that promote spread. So, but I don't know that we can adopt that if we don't have a good quality scan. So I'm not sure I'd bet myself back with that one and say,
Well, there's no issue with the micro ultrasound in metal.
Nope.
You're bypassing it. You don't have a beam coming in from the side because you have the probe right against it. The probe has to be right up against the prostate. Regular ultrasound, maybe 3 to 5 centimeters. With this, it's probably 2 centimeters or less in terms of the hot spot or the clear spot on the ultrasound. As the frequency and sensitivity of the ultrasound increases, the depth of penetration decreases. So it's not like you're shooting in all the way from the side as you are with the MRI.
Gotcha. Thank you.
Yep.
And I'll just correct myself. I just searched, and it says that Mayo doesn't have the exact view yet. So So you're probably right, but I would just write them and ask them.
I will, and then I'll also ask if he thinks it would benefit if he wanted to refer me to somebody to get that specific test
Yep,
done.
yep.
I think that's great. Okay. Anything else from Michael?
No, I think I've taken up too much time. Thank you, though.
No, yeah, you're fine. Thank you. Zala, you're up.
Great. Hello, everybody. So a couple of small developments since last time. I did have Dr. Zhou reread my biopsy from U of M, where I had 3+3 and 1 3+4, and he did confirm those. So his review was, spot on and aligned from the people from U of M. I did send him both my previous MRI from my previous urologist, and I guess he never got those slides. But we had a nice talk today for about half hour, and he gave me some good information, Dr. Zhou did. And I asked him, what would you do if I was your brother? Because that's what Tim told me to ask him. And he goes, if you were my brother, based on your Prolaris, which is 3.5, and your PSA of 26, I would probably have the surgery. But that doesn't mean you can't first look at other options with an oncologist and radiation person. And with that said, I switched to another doctor at U of M that Rick had referred to, Dr. Morgan. So I have an appointment with Dr. Morgan in a week from today at U of M.
Okay.
He's as good as they get, Dr. Morgan. So he's really a good guy. So.
Okay.
And Rick, I was going to ask you, all those blood tests you described, I mean, is there any, Dr. Zhou was saying some of the things I was talking about screening that he goes, at this point, there's no need for it because we know you have some type of, you have some cancer, you have the PSA number, and you have your Prolaris score.
Yeah, so I will flip. It wasn't me. It was probably Dr. Mark who was talking
Yeah,
about.
I'm sorry, Mark. Yeah, Dr.
Dr. Mark. So I'll flip that over to Dr. Mark. I mean, the question is, should you run a different one if you've already done Polaris? And I mean, there was some recent research that says that they're pretty much all the same. They're pretty consistent, whichever one you use, but you may not agree with the research. So I don't know what Dr. Mark thinks.
All I will say on that is the information on Decipher. There's a lot more information available. There are people who think that Decipher tends to appear more aggressive or that the disease is more aggressive than not. They had just expanded this week with some new indications for Decipher. But I also think that, looking at the AI, Arteria AI might be a helpful tool. I'm not one to rush into surgery. Certainly not now, but whenever I went into an operating room, I wanted to know that what I was going to go was absolutely the best option. And with prostatectomy, there are a few situations where I really believe it's the best option for people. For disease that's confined to the gland. Your issue is that we're not going to find studies that have people with stem inserted who couldn't have an MRI and then had no lesions show up and have a rising PSA. So you're in a unique situation. And I think more than when you do a test, you want to know which population the test was validated in And does that really apply to me? And I think in your situation, I'd be cautious, regardless of the test you do, as to whether your situation is similar and whether you can apply that and say, yep, this is what the test shows, so this is what I have to do. I think it's working with a physician who you can trust, who's knowledgeable, and can help you go through the pluses and minuses of each approach. But again, I'm not big on pushing surgery because there are too many people who have side effects and have to deal with it.
Yeah, and I get all that, and the more and more I read about the side effects, the more and more that scares me, deters me, and that's not my first option. But I read Dr. Morgan's bio, and he says even though he's a surgeon, his go-to methodology is not just always, radical prostatectomy. He works with the patient to decide what's best for the patient. And
But it's interesting. There is a study called the Hermes study, which looks at 2 sessions of radiation, and there are 2 other ongoing studies looking at doing SBRT with just 2 sessions, and not getting into all the nitty gritty of the radiation physics. It appears there may actually be some benefit by doing fewer sessions than spreading it out over 28 or 45. So I think the day where let's just do 28 sessions or 35 sessions so it will be safer is not necessarily where the science is right now.
great. Yeah, I'll know more Monday in which direction I want to go. And right now, if I can, I'm leaning toward the SBRT, and I've heard about the CyberKnife thing. I don't know a whole lot about it, but I guess I'll have this discussion with Dr. Morgan. Go ahead.
Yeah. So one of the things, CyberKnife, the advantage is that it is monitoring live. Usually it's monitoring the 3 or 4 fiducials that they inject surrounding the prostate so that they know where they're aiming and whether those spots from day to day are in the same location as the beam is going to be coming. The advantage with the CyberKnife is that the head of the machine can rotate not only 360 degrees, but really an infinite number of angles. So it's not like with Proton where you're putting all that energy in through just the 2 spots and you run the risk of skin burns. Almost never heard of with CyberKnife. There's some differences in the beam collimating and the ability to actually see the lesion while the beam is on with a CT guided machine and an MRI guided machine. I still think the MRI is state of the art, but with the CT guided machine, they are cutting the margins of normal tissue that's being radiated. And the side effects come from not from generally from hitting the center of the prostate, but what's at the edges of our prostate gland, the bladder neck, the bladder, the rectum, which kind of lie toward the outside. So the smaller normal margin you put around the tumor when you're radiating and being able to adjust that during the course of radiation may offer an advantage.
Gotcha. Just to follow up on your, I think this is applicable on your comment about pin the tail on the donkey, that my first MRI, they found 6 of 12. My second MRI, they only found 4 of 12 samples. So I think that's what you were talking about.
Well, I'm thinking that, again, you don't even know where the lesion is.
No, I mean, I'm sorry. Did I say MRI? I meant biopsy. First biopsy was 6 of 12. Second biopsy were only 4 of 12.
Well, there's going to be variation, but it's just a function of do you even know where you're aiming? And the amount of biopsy tissue that they remove from the prostate is so small compared to the entire gland. Even when you know where you're going, there's the possibility that the needle torques a little bit or the specimen breaks right at the spot that's most severe. So you don't always know that the biopsy, it's a good guess, but it's certainly not 100% on.
Right. And I just wanted to add for you, Zolly, that SBRT is a type of treatment, a type of radiation, and CyberKnife is one of the machines that does SBRT. There are several machines that provide SBRT.
It's a brand name. Yeah.
It's a brand name, and Dr. Mark can tell you a lot more about the different machines and which one is better or which one is worse, because he's an expert. Don't ask me, but I just want to clarify for you that if you want to know more, if you're asking Dr. Morgan about SBRT, the difference between SBRT and CyberKnife, CyberKnife is SBRT, but it's only one way of doing SBRT.
Perfect. I'll look smarter then. Thank you so much.
The other thing then is if you're looking at radiation with a shorter course, ask what he feels about the Prostox text. We have a webinar on our site on AnCan.org. I cannot pull the link out, but we had Dr. Joan Whithouse, is it?
Yeah,
And
Joanne
Whithouse. And
Yeah.
she developed a genetic panel that allows a prediction of whether someone's at high risk for late side effects from increased rate of delivery of the radiation. So the difference between IMRT and SBRT is how many gray or how many units of radiation you give in a single day. So the faster ones require more repair, and they do a better job killing because you're putting more energy into that area. But there's also a greater risk of side effects if you have this genetic panel. It's about 7% of people that are going to be at risk, and those people might do better with the lower, slower, but that's a small percentage. It's not the majority of patients who are getting this SBRT radiation. So ask them what they think. It's relatively new, so they may not have extensive experience with it yet.
Can you say the name of that again, please? Prostox?
Yeah, I've just posted it in the web in the chat window for you, including a link to the presentation. It was about a month ago we did it, wasn't it, Mark?
Yes. Yeah.
Thank you so much for posting that. Thank you, everybody.
Okay. We did have
I'm going to have to sign off, so thank you again, everybody. I appreciate all your help, and I'll let you know what Dr. Morgan says.
Okay, say hello to your wife.
Okay, Maria. You know she's here.
And she's hiding.
She is hiding. Thank you.
She doesn't have to hide. We love having the ladies in this group. They're very, very welcome all the time. Right, Dr. Mark and Dr. John?
I'll drag her in next to me next time.
That's great. So I'm excited. Tomorrow I'm having dinner with one person who is finishing up SBRT at UCLA and another who's just coming to get started on his SBRT. So I get to sit in the middle of the before and after. Okay. Unfortunately, Michael, I guess, stepped away. Anybody have any
Edward.
comments?
Edward came in. Edward went out. Edward came in a few times, and
there he is. Edward, you're up.
He's on a call.
Does that mean he's calling in?
I don't know what that means. Now he's arrived again. I don't know. I think he's having some problem.
Are you with us? Edward, are you here? Well, while he's trying to figure this out, anybody else have any other thoughts or prostate issues to share with us?
I have a question, Mark, that came up earlier in the group. When is it appropriate to do another biopsy in such a short time as 1 year?
I don't know. That would be an active surveillance group. I'll send you to the active surveillance group to get an answer of that.
Okay.
I think the problem with coming up with an answer like that is the fact that we're making these decisions based on tools that we didn't have when we were gathering information.
Yeah.
So, I mean, we have so many new biomarker tests now.
Yeah.
The MRIs that we're doing today are very much different than 5 years ago. Many are turning to the biparametric MRI. So, I mean, I was put in that position where I was told, yeah, I mean, it's 2 years, 3 years, 4 years, 5 years out. You should consider another MRI and biopsy.
Mm-hmm.
And I was thinking, you know, my PSA is undetectable. You tend not to develop disease that is going to be not producing PSA from as a BCR. You're going to BCR first, you're going to have disease, and then it will progress. But after initial treatment, so I don't know. There are some people who are getting MRIs and biopsies on a more regular basis, but I'm thinking, you know, as we heard earlier, maybe the routine biopsy does not need to be done. And if you look at Klotz's data, while that was mainly on initial patients, can you apply that to BCR? That if you have someone who's stable or been treated, if the MRI is negative, do you still need to do biopsies? I don't think so.
Mm-hmm. Thank you. Yeah,
Your thoughts?
I just kind of cringed a little bit at the idea of repeating a biopsy in 1 year nowadays, and I was wondering. Thank you.
I mean, I've heard mostly 2 years if it's going to be a routine thing, but the idea of routine biopsies just doesn't strike me as a fun way to proceed unless there's some evidence that you're at a greater risk. I mean, if someone came in and their initial biopsy had a very high Decipher score, then I might say, you know, that, and you saw a rapid rise in the PSA along the way, then I'd be more aggressive. I think one of the problems in this world of prostate cancer is that the questions we ask are usually based on a single piece of information. And in order to really decide what to do, we've got to take into account all the variables and a number of tests and try to put all that together to come up with where we are. So I think the hard and fast rules are kind of not as useful anymore. Rick, what are your thoughts on routine biopsies?
Well, clearly the men don't like them. And I think that's a very important factor. Secondly, I think that you also have to take into account who is doing the biopsies. I think they're much less likely to occur in a academic practice center of excellence than they are in a local practice. So you have to have your antenna up. If you're with a community practice urologist and they want to biopsy you on a very regular basis, I would be concerned. I think what drives it for me is if there's something untoward that happens. I mean, you know, if you're cruising along, what is it they like to say in the AS group? the trend is your friend. So if you're cruising along at a PSA of 6 or 7 or 8, and there's not much change, and then suddenly you do a PSA and it's gone from 8 to 25, then yeah, there's probably a good reason to get another MRI and do another biopsy. You know, and as you know, in at AnCan, we pretty much ask you to insist on a transperineal and not a transrectal biopsy at this point in time. And that makes it also difficult because a lot of the community urologists don't do transperineal, and they'll tell you it makes no difference. It makes a big difference. And now there's the research to back that up. But I would say why? Why do they need to do one after 12 months? I would be questioning that and make them justify why it has to be done. Put the onus back on your doc if they're asking to do a biopsy within 12 months. Has anybody in this group been in that situation where somebody's wanted to re-biopsy you within 12 months? Stuart, go ahead, please.
Yeah, well, it happens. I've seen it happening more when you switch doctors. They all want their own biopsy. When I first went to NYU, which was 3 months after my original biopsy, the doctor said, first thing, if I'm going to treat you, I'm going to repeat the biopsy because I want to see it for myself. And I know from listening to AS group for my brother, and what he's been told by the docs was they all said that we're going to watch the blood tests and we're going to watch the MRI, but it's very likely we're going to do another biopsy at 12 months to make sure we know that the first one was right. So I think it's it depends on the circumstances.
Bill,
I think one of the other things that can happen along the way is you may be sitting in a situation where there's a clinical trial and you want to know, is this biopsy because it's a good idea and necessary, or is this biopsy part of the clinical trial data that you signed up for going in? So that's something to ask about. Bill, you had your hand up.
Yeah, I had a confirming biopsy 6 months after my first one. I think the trigger there was I had a MRI with a PI-RADS 5, but they weren't certain. They said, but it's hard to tell due to prostatitis. So they did it in 6 months later.
Yeah, I think that's kind of different in that it's not the concern was about the reliability of the initial biopsy, or a lot of times you may get a piece of tissue that's not solid, or the needle core may not be long enough, or may pull back and may be harder to read. So just saying doing a biopsy and meaning you have great tissue to evaluate doesn't always happen. There are some tools out there that people are looking at introducing to improve the quality of the tissue that's used for the biopsy. Michael, you had your hand
Well,
up.
of course, I had discussed or mentioned earlier that I'm having a repeat biopsy at a year now, but certainly I agree. Nobody looks forward to having a prostate biopsy. I don't look forward to having the bleeding that I see afterwards. And I think it plays on you psychologically. But now I am going to say that, I don't disagree in my case with repeating it a year. I've changed doctors. I you know, I kind of want to know where things are myself since I had an upgrade last year. And lastly, I will say that, and I am a nurse practitioner, as y'all know, but at Huntsman, they have the nurse practitioners do the biopsy. And this time I'll be having an MD, a surgeon, do the biopsy. And quite frankly, I'm fond of that idea, you know.
Any other comments? Edward, I guess if you want to try, we will see if we can hear you. We couldn't hear you and couldn't see you. So it may be that we have to do this again another time if it doesn't work. You may be able, I see that you're calling in as well, and wondered if that's something that might work on the phone call rather than on the computer.
Can we hear you, Edward? Say something.
Hello.
We got you. We got
Okay.
you.
Good.
Great. So this is your first time in the group. So if it's okay with you, I would like to ask you some questions, and then
Sure.
we'll open it to the group to comment. First of all, do you have a last initial that we could have?
Oh, B.
Okay. And have you been to the website to sign up for reminders about the group? If not,
Yes.
you can. Okay,
Yeah.
great.
Yeah.
How old are you now?
68.
And where do you live?
I live in Florida.
Okay. And when were you first diagnosed?
22.
Okay. And how did you get into the system? How did you get a diagnosis? What got you to the doc, and how did that progress?
I had a rising PSA on physicals. Went from 2.5 to 4 and 20, and then 21 I went to 4.5, and they said go do a repeat another PSA in 2 months, and then it was 5.5. So then I went to the urologist in 2022 in March, and PSA was 6, and he said, let's do an MRI. I had one of those multi-parametric MRIs, which showed an 8-millimeter lesion on the left lateral peripheral zone in the apex. And then about a month later, I had a biopsy.
And
in 2022.
And what did that show?
That showed, nothing from the target, and both the left and the right had some 3+3. I remember it was like 30% on one side of the, and 40 on the other, as far as the amount in the core.
Okay. That may or may not be relevant. Have you sent the tissue off for a second opinion read?
Well, that was in 22. So then I had about 2 years of active surveillance. And no, I didn't get a second opinion that time. So then I had another biopsy in September 24. And 4+3 showed up at the lesion. And that was 40% of pattern 4. Okay, so that's 4+3 on the left, and there was only 3+3 on the right. So the urologist said, "Okay, go up to Moffitt Cancer Center," and I saw a couple of radiologists, and I asked one to do a PET PSMA, This is in December of 24, and I had 16 SUV on the right, on the left, and 13 on the right. So, I guess in the prostate, yeah.
Okay.
Yeah, and go ahead.
Have you had a second opinion read on that 4+3?
Yes, I did. Yeah, Dr. Zhou did that, and he agreed that it was 4+3.
Any cribriform pattern or perineural invasion or intraductal mentioned in the report?
At that time, yes, there was some cribriform.
And did they mention, say, like large cribriform? Or now it used to be just, do you have cribriform or not? Now we know large cribriform is significant, but small cribriform pattern is really not prognostic.
Yeah. Well, in that one, no, it wasn't mentioned. I did talk to Dr. Zhou, but I have had a subsequent biopsy, but anyways, I'm getting ahead of my story. But
okay, I'm sorry.
So no, that's okay. So anyways, I had that PSMA, and they really, I even talked to a urologist at Moffitt about doing IRE and as well as surgery, and he said he would do either one. So then that was in January of 25. So then I said, well, I'm going to go see Evan George. So I saw him at Johns Hopkins, and he said, well, whoa there, you got that uptake on the right side, and I want you to have another biopsy, do it transperineal, and so I had that done at Moffitt. This is in April of 25. So this time it was 3+4 on the left, 4+3 on the right, and so on the second opinion that I had Johns Hopkins do, they said the cribriform was less than 12 lumens, which that's what all I remember from that. They didn't really say it was large glands or
that would
small.
Be small. That would
Good.
be considered small and less concerning. I think 20 is the cutoff on that. But so what options did you get? Did you see John Stone at Moffitt?
No, I saw Pao Sang, the surgeon.
Okay. And Dr. Moffitt is one of the radiation oncologists who is doing the MRI LINAC, and it would seem that would be the easiest thing.
Right.
After you do the Prostox screen, you go into the chat room here, you'll see Prostox seminar, a link to that, and it will explain how that Prostox genetic screen can help predict long-term risks for higher rate radiation treatments.
Right. Well, one issue that I've come across here in Florida is even though the websites for Moffitt and Orlando Health indicate they do MRI LINAC on prostate, they don't. They just went offline at both places in May because they're not renewing the contracts.
Really? I can't imagine why they would have made such an investment. Tim, have you heard anything about that? Tim is also in Tampa and was involved in the Moffitt system.
I have not, Edward. I haven't heard of that, or Mark. I had the Meridian LINAC with Dr. Johnstone, and I did have a lot of exposure to Dr. Pausang, who I thought was great.
Yeah, but I'm not familiar with Dr. John Stone. I never heard of that name at Moffitt.
Oh, it's one that's his last name is Johnstone.
Oh, Johnstone. Okay, yeah. So, anyways, I mean, they just went offline in May. They sent it to the boneyard. They're done with it. They told me. So I've talked to radiation there. They offered me HDR.
Well, I was in Atlanta and had 4+3, and I had done Tulsa,
mhm.
and then ultimately delayed doing my PET scan because of COVID, and the only place I could get it was traveling to LA. So I skipped and did the Tulsa, and then 3 months later did the PET scan and saw that I had involvement in seminal vesicles. And after looking around, I felt most comfortable with MRI Linac and came out here to Los Angeles.
Yeah.
The two people that you might look to would be Dr. Kishan in LA, Dr.
Mhm.
Nagar in New York City,
Yeah.
or closer to home at Tampa General. I think, and the name will pop in my head in a minute, Rod Ellis is a great and well experienced, and I think he's using CyberKnife and smaller
Yeah.
margins.
Collins there. Yeah. Georgetown is there.
You're breaking up. I'm sorry. Any other comments
Yeah.
for Edward? Edward, what questions do you have for the group?
Well, I'm wondering, is there a difference in MRI Linac machines as far as imaging and margins between Elekta and Meridian?
There are slight differences between the machines, but no, I would think you would do well. They both have adaptive radiation therapy. They both have automatic gating. They both are going to have the reduced margins. So if you found the MRI Linac, I know that they have one at MD Anderson, but I don't think they're treating prostates with it.
Okay.
But I don't know where else to. Oh, Dr. Nagar in New York has got an
Yeah.
Elekta Unity
Yeah, I
machine.
do. I have an appointment with him in July.
He's really sharp. You might ask him. He does not feel strongly about this Prostox testing, so you might want to look at that. The other thing you ought to ask in your questions is about Barigel or SpaceOAR gel to protect the rectum.
Right.
And whether you would be a candidate for one of the studies with a 2-session Hermes. Hermes is the one that's completed, but they had no difference comparing 5 sessions to 2 sessions in terms of side effects. So that might be something to look at as well.
Okay.
Or at least ask about.
Right. And is it now standard treatment to do a boost to the DIL?
It depends on what machine you're using, but certainly that's capable with the MRI Linacs. You want to. The problem is the prostate can move, so you can boost the lesion, but if things move while the beam is on and you're not tracking it, you'll run into issues there. So I think that the boost would be common. Normally they'll boost it maybe 2 gray to the area where the lesion is seen. One of the problems with the MRI, and there was an interesting paper that I just came across. I have everything prostate Google searched and mailed to me twice a day with all the research and stuff. But it was showing that between the different methodologies of MRI, you're going to have 2 or 3 or 4 different mechanisms or protocols for doing the MRI. And if you look at them and then measure the size of the lesion or predict the size of the lesion, they can vary by 50 to 75% or more in size. So one may say, yeah, the lesion is 0.75 and the other says 1.4 centimeters. So in terms of which one do you, what protocol do you use to guesstimate the size? I don't know. But if you throw this variation in size in there with movement, you want to have the best focus beam and you want to have the ability to track movement. So,
And that would be with the MRI Linac.
yeah.
So, yeah.
Or,
Okay.
and then the second thing would be the CyberKnife. But again, with CyberKnife, the issue is you're still running off of the gold seeds.
Right. Yeah. Yeah, I understand that. It's they're relying on that, and for those not to move out or anything.
Yep.
Yeah.
Let's see here. I think I do have one more hand up here. Paul Ann, go ahead.
Yeah, it's just you guys can hear me? Okay.
Yes.
Can you guys? Okay. So this is a suggestion regarding the Prostox. If I'm sorry, whoever is talking right now. If you have problem getting a doctor or like the particular doctor in New York that doesn't really quite believe in it, so what I did to get around that is I schedule a virtual visit with Dr. Keyshawn at UCLA, and then basically before I even asked, he went ahead and put in an order for a Prostox test for me because he was one of the original team members who developed the test. So that's a suggestion. If you, like I said, some doctor, my oncologist that did treatment, I mean radiation treatment. When I first approached him with that, he said, I know very little about it. I can't order it for you. So, so once again, the suggestion, if you just schedule a virtual appointment with Keyshawn, and he will order one for you, most likely. Yeah.
And they're both great docs. I've spoken on panels with both of them, and think very highly of their approach, their research, their honesty, and have had nothing but good feedback from people who've seen them. So,
Yeah.
okay, well,
yeah.
Anything else here tonight? Thank everybody for coming in, and have a great week. Those of you in the center of the country, stay cool. We have nice, cool weather here. And we'll see you in a couple of weeks.
Thank you.
Good night.
Thank you.
Hold
Great
on.
meeting.
Hold on a second. Don't forget that tomorrow is Veterans Speaking Freely, which Colonel Boykin and Bill Franklin moderate, and it's open to all vets. So I don't know if anybody's on here. Oh, Michael, that might be one for Michael. It's a really good group. We recommend it. So and let your veterans friends know about the group too. If they want to get anything off their mind, that's the group to go to. So I'm trying to think if we have anything else this week, but I don't think so. So that's it.
Okay. See y'all later.
Bye.